Axial spondyloarthritis include ankylosing spondylitis, reactive arthritis or Reiter's disease, psoriatic arthropathy, and juvenile spondyloarthropathy. All these diseases have common features which include human leukocytic antigen or HLA-B27 gene, inflammatory back pain, negative serology for rheumatoid factor, absence of rheumatoid nodules, and asymmetric oligoarthritis predominantly of the lower extremities. In ankylosing spondylitis, the spine is the primary skeletal site involved, usually starting in the sacroiliac joints and lumbar spine and progressing cranially. The locus of involvement in ankylosing spondylitis is the points of attachment of tendons, ligaments, and capsules on bones, with replacement of ligaments by bones leading to osteoporotic vertebral bodies, calcified discs sparing the nucleus pulposus, and ossified ligaments. The final result or image is of square appearing vertebral bodies with bridging syndesmophytes, which is famous by the sign bamboo sign on plain X-rays. In ankylosing spondylitis, neurosurgical involvement would take the picture of coda equina syndrome, spinal deformity or stenosis, spinal cord injury, which usually occurs in the lower cervical spine, myelopathy due to bowstringing of the cord, basilar impression or invagination, rotatory subluxation at the atlanto-occipital or atlanto-axial joints, and Anderson discovertebral lesions. Extra-articular manifestations include anterior uveitis, inflammatory bowel disease, and psoriasis. Ankylosing spondylitis has an incidence of 0.4 to 7 per 100,000 population per year, with peak incidence between second and third decades of life. The typical initial presentation includes non-radiating low back pain, buttock pain, morning back stiffness, hip pain and swelling, probably due to sacroiliac joint involvement, which is the main feature for diagnosing ankylosing spondylitis. Other criteria for diagnosis include psoriasis, inflammatory bowel disease, enthesopathy, and positive X-rays. Radiologic investigations in ankylosing spondylitis include AB and oblique X-rays on the sacroiliac joints, which show symmetric osteoporosis followed by sclerosis, thoracic spine X-rays, which may show progressive kyphotic deformity, whole spine X-rays, which show bridging syndesmophytes between vertebral bodies, the bamboo sign, and may show non-contiguous fractures. CT will show the same findings plus missed cervical fractures. MRI may show dural ectasia in coda equina syndrome, spinal epidural hematoma, Anderson discovertebral lesions with pathologic changes at the ligament attachment sites at the front and the back of end plates, and may show erosive changes due to pseudoarthrosis at the disc space, which may mimic discitis. And finally, bone scan, which may show increased uptake in sacroiliac joints in relation to the sacrum. Differential diagnosis of ankylosing spondylitis includes rheumatoid arthritis, metastatic prostate cancer, Forstier's disease and DISH, diffuse idiopathic skeletal hyperostosis, which cause bony overgrowth at the front and the back of the disc space without degeneration of the disc, and also sparing the sacroiliac and facet joints. And finally, reactive arthritis, psoriasis, and enteropathic arthritis, which are usually milder and less uniform than ankylosing spondylitis, and also with asymmetric involvement of the sacroiliac joints. Progression in ankylosing spondylitis is usually slow, and most patients remain functionally active. Progressive thoracic deformity associated with involvement of the costovertebral joints predispose the patient to restrictive and later fibrotic lung disease. Also, progressive thoracic deformity lead to a compensatory increase in cervical and lumbar lordosis with shift in center of gravity associated with spine stiffness and fragility, which predispose the patient to recurrent falls and choke stick fractures, which may involve all three columns of the spine, rendering it an unstable fracture. The main goals of treatment are long-term quality of life with symptomatic control, usually by non-steroidal anti-inflammatory drugs, and the prevention of progression of structural damage by multiple groups of drugs. The majority of thoracolumbar fractures in ankylosing spondylitis occur at the thoracolumbar junction. They have three types: shearing injury, typically acute, involving all three columns of the spine, and this is usually an unstable fracture; compression fracture, typically chronic; and pseudoarthrosis, typically subacute from previously missed fracture. Severe disabling deformity would be corrected at the same time during fracture fixation using corrective osteotomies. Surgical considerations before operating on patients with ankylosing spondylitis include extensive preoperative evaluation of the fracture using CT and MRI, avoid neck hyperextension to avoid exacerbation of the neurologic deficit, be prepared for difficult bony anatomy and obscured landmarks, consider extending the construct or the fixation system for multiple levels above and below the fracture site. For example, for cervicothoracic fracture, you may extend the system up to C2 pedicular screws and for multiple thoracic levels below the fracture site. Prepare a good fusion bed and consider using iliac crest bone graft or allograft like PMMA augmentation, polymethyl methacrylate, and mobilize the patient early after surgery in hollow vest or thoracolumbar orthosis.